Good evening, everyone. Welcome to the third in our series of 4 of the Binding Blocks Nuclear Physics webinar series. My name is Chris Stewart. I'm the host for this evening's webinar, as usual. Back again to get us through the next hour. Just a little bit about me. I'm a local freelance, local being York-based, freelance science communicator. Used to be in a particle physics, nuclear physics. Now I just talk about science a lot. Enough about me. On with this evening. Tonight, as I said, is the third in a series of 4 of these nuclear physics webinars. In the first week, we talked about what are all of the elements in the universe and where did they come from, all the different kinds of nuclei that you can get inside atoms. What are they? Where did they come from? Last week, we talked about nuclear fusion as a potential future energy source for the planet. How would that work? How would you even make that? Next week, we're digging right down into really the heart of the nucleus, the core of the atom, to find out what's the nucleus made up of? What are all these particles and what are they made from? But this week we're talking about nuclear physics as applied to the incredibly important realm of medical physics. So as usual, we have 2 speakers joining us tonight, and I'll be introducing the first of those in a minute. They'll each speak for about 15 minutes. And around that, we'll have some Q&A. So the first thing to mention is if you've got any questions tonight that you want to pose to our 2 speakers, then throw them into the Q&A chat, which you can find at the bottom, down the bottom of the screen there. Put those up and we will go through all of those and ask a selection of those questions as we go along. If we don't manage to get to your question tonight, really sorry about that. We have limited time. But look, if you're doing the masterclass, if you're one of the participants in the nuclear physics masterclass, hello, welcome. You can put your questions into the question forum on the masterclass webpage. So if we don't get to yours tonight, just hang on to it and throw it into the forum there. The other thing that's worth mentioning is that if you get thrown out of the session tonight, if your connection falls down, you can rejoin again, just using the link that you were given as part of the original invitation to join us on the webinar tonight. So just come back in again as well. If you do have, or if you want to turn on the closed captions, the subtitles, those are automatically generated, which is always entertaining to see how the artificial intelligence tries to figure out what we're saying. You can turn that on down the bottom of the screen and one of the buttons there as well. Some of you may also have found as you went along that we do have the reactions button there as well. So as a big thank you to the speakers at the end of their session, you can use the reaction button to send through your applause, your love hearts, your whistles and so on. But listen, enough about that. Oh, the other thing I should point out is that tonight we are in fact being recorded, and we will be putting the recording of this session up onto the masterclass website at some stage in the not too distant future once we've managed to pull all that together. So you can relive tonight's session and go back over your favorite bits. Enough about that. Tonight we're talking about medical physics and medical nuclear physics, and so it's my great pleasure to introduce the first of our speakers, Dr. Silvia Pani. She's joining us tonight from the University of Surrey, where she is a senior lecturer in applied radiation physics, and her research speciality is medical X-ray imaging. And tonight she's going to be talking to us about color X-ray imaging, which is intriguing because in my mind, X-rays are purely black and white. So welcome, Silvia. It's great to have you with us. Please take over the webinar and begin your talk.
Thank you very much, Chris. Thank you, everybody, for attending. So let me start by sharing my screen. Okay, so tonight, as Chris said, we're going to talk about medical physics. So what is medical physics? Well, you have all the definitions from the European Federation of Organizations for medical physics, but in a nutshell, medical physics is about applying physics to healthcare, so treatment and to diagnosis. So if you have questions like these, my leg hurts, what can I do? My GP has referred me for an MRI scan, should I do it? Or what is the situation with COVID? these are questions for a doctor. As medical physicists, we're not clinically trained, so that's not what medical physics is about. As a medical physicist, I can explain, so I cannot tell you whether you should take an MRI scan, because that's your doctor's decision, but I can explain to you how an MRI scanner works. Or I can give you an idea of how the radiation dose you get if you go for a CAT scan compares to the general radiation dose that you get from day-to-day environment. Or I can tell you a bit about proton therapy. Actually, it will be our next speaker who will do that. But that's pretty much how I like to picture a medical physicist. I see myself very much as a hands-on person, and what drew me to medical physics was the idea of doing something that could be applied to people's benefit. Okay, now your next question will be, okay, but I have signed up for a nuclear physics masterclass. So what is this about? Why medical physics now? It's because many of the modalities for diagnosis, so for identifying illnesses and for treating illnesses in medical physics, are based on what we call ionizing radiation. So you may be familiar with the term. It's radiation that has enough energy to extract electrons from matter. And nuclear physics explains how the radiation we use for diagnosis and treatment can be produced, and how it interacts with the human body. So medical physics, a good chunk of medical physics, really couldn't exist without nuclear physics. And also, if we take the technology that we use for medical physics, it's actually a fairly close relative of the technology you may have seen here on the left-hand side. So there's the Large Hadron Collider. And many of the detectors, for instance, for medical physics, stem from detectors that were originally developed for nuclear and subnuclear physics. And also, for instance, at CERN, the data need to be processed, for instance, to find out what type of interaction has happened and where, if a detector received a certain signal. And this is also what we can do with this machine on the right-hand side, which is a scanner for positron emission tomography. So it's very similar. You inject a radioactive substance in the patient, and you will have detectors all around the patient that will receive the radiation that has been emitted from inside the patient. And you need some algorithms that are not too dissimilar from the ones that scientists at CERN use to reconstruct where the particles have been emitted from. So I'm a medical physicist. My route into medical physics was a pretty traditional one, apart from the fact that I trained in a different country. I'm originally from Italy. So I had a degree that was equivalent of what is an MPhys here. So it was a research-oriented degree in physics. Then I did a PhD, which are 3 or 4 years of research, building my own research project. And that's where I chose medical physics as my specialty. Then I had a few temporary research jobs in Italy and the UK. And then eventually I landed at the University of Surrey 13 years ago. In my day-to-day job, I test new X-ray detectors. I try and find new applications for them. And I also collaborate with a range of very different people, which is one of the things I like about being a medical physicist. I supervise PhD students, and I also collaborate with people like electronic engineers who provide the technology, with clinical scientists, and with medical doctors. And a big part of my job is also running a master's degree in medical physics, which is really exciting to get to train the next generation of medical physicists. Okay, so I mentioned, and Chris mentioned in his introduction, that I work on X-ray imaging. So you may already be a bit familiar with X-ray imaging. So we have an X-ray source, we have a detector, the patient sits in front of the detector. The X-rays are absorbed differently by different parts of the body, so we end up with an image like this one. And more in detail, so there is a picture of a hand. It's not a very famous hand of Mrs. Röntgen's. That was the first medical X-ray image that was ever taken. So in a digital detector, in a standard X-ray detector, which is not too dissimilar in technology from your mobile phone camera, for instance, we get a black and white image. And how do we interpret this information? So different regions in the body stop X-rays differently. So dense regions like bones stop X-rays quite a lot. So the emerging signal is pretty low. So the signal on the detector appears as white in a grayscale. Intermediate regions like muscle and soft tissue have an intermediate attenuation for X-rays. So the signal we get on the detector is some gray level, some darker gray level. And all around our patient or our object in the background, as there is no object between the X-ray source and the detector, there is no attenuation, so the signal is maximum, and it translates into dark in a typical X-ray image. So effectively, we're imaging shadows. So the thicker the shadow that an object casts on the detector, the whiter that region will be. So this is all very good when we're trying to image a hand and detect fractures, but there are cases where we have, for instance, a thicker region of the body or regions with non-uniform background, where a standard X-ray image may not give us enough information. And to help, one of the approaches is to use what is called dual energy imaging. So the idea is that we take X-rays of different energies or of different wavelengths. So you may be used to talk about wavelengths for radiation. In medical physics, we tend to use energy that is inversely proportional to the wavelength of a radiation beam. So different energies are stopped differently by a certain material. Typically, the lower the energy, the higher this quantity called mass attenuation coefficient that tells us how much X-rays get stopped in a material. So what is important is that if you look at the graph below here, you see that not only the fraction of the initial intensity that was hitting the object changes with low and high energy, but also for different tissue types. So the ratio between the fraction emerging for bone and for soft tissue changes as we change the energy. So the blue and the orange band don't grow proportionally to each other if we change the energy. And that's what allows us to use some very simple algorithms to combine images at two different energies. For instance, to differentiate, so to get separate images of soft tissue and of bone, or we'll see later, for instance, fat tissue against glandular tissue. And we have an example here. So we have two images of a patient's chest at two different energies, and you see that there isn't much difference between the two. We combine them with a very simple algorithm. It's basically solving two simultaneous equations, which I'm pretty sure you will have done in school by now. And we end up with an image where only soft tissue is visible, so without the rib cage masking the structure, or an image where only the bone structure is visible. And the beauty of this is that it can be done with a very, very simple algorithm. Problem is, to do this, we have to acquire two images, so expose the patient to radiation twice. So we want to keep the radiation dose to the patient low, and also the risk is that if the patient moves in between the two exposures, the two images may not overlap correctly or register correctly, as imaging scientists say. So what can we do? The idea is to acquire two images at different energies with a single exposure. So let's see how we could do it. We could do it using color X-ray imaging, which was the original title of my presentation. So is it really a thing? As Chris said, we are used to seeing X-ray images of that are just black and white. Now, let's go to the visible light, to a visible light example. So here we have a picture of a forest. So we can clearly see the structure of the trees. There is a fence. There is something that from what we could see here could be either a footpath or possibly a stream. We don't know, for instance, if the picture was taken in winter or in summer. So if we could have color information, so information about the wavelength of the light that has been reflected by all the objects in this picture, we could get a lot more information, and that's what we get here. So we can tell now that it's an autumn landscape, and that this was actually just a dirt track, not a stream. Can we think of doing something similar with X-rays? So basically, we will not get an image that looks multicolored in X-ray images, but we want to get some information that preserves, so we want to preserve the information about the wavelength or energy of X-rays. So the idea is that if we have an X-ray source, it will emit X-rays that have many energies or wavelengths. So this is what is called the spectrum of the radiation coming from a standard X-ray source. So it's the energy distribution of the radiation. So this beam with this energy distribution hits our detector, and a certain pixel will give a signal that we will call X. This is a single number which results from the energy deposited by all the wavelengths that were present in our original X-ray beam. But we cannot tell from this number X how much of this number will come from this energy component or from this one. This is something that can be done with a color X-ray detector or a spectroscopic detector. A spectroscopic detector will process every single hit, every single photon that has been detected, and it will retain the information about the energy of X-rays. So a spectroscopic detector for each pixel would give us something similar to this histogram, effectively. So the good thing about this is that we can acquire many images at different energy with a single shot, so a single exposure. So we only give our patient one lot of radiation dose, and we don't have any risk of blurry images if the patient moves in between the two acquisitions. So going back to how all of this ties in with nuclear physics. So this is how a standard nuclear physics setup compares to my setup. So this is a standard nuclear physics setup. The detector is actually hidden in behind these LED bricks here, and the box on the left is all the electronics that is required to control the detector. And below you have a plot of the type of information you would get in nuclear physics. This is the detector I'm working on. It's a fairly small box, and the actual detector is behind this little window, which is about the size of a large stamp, let's say. So it's pretty small. And get information about like this. So there is the spectrum, so the energy distribution from our X-ray source. So I'm going to show you an example of some work that we did to start with a simple case, which involved separating so getting two separate images from a test object that contained a set of plastic spheres here. And to the front, we attached a small piece of plastic with some holes where we injected some iodine contrast agent. Iodine is a contrast agent, which means that it's a material that can be used to enhance the visibility of some regions in X-ray imaging. So we take of all the from all the information of different energy that we obtain from our detector, we pick two. We get these two images. They don't look too good, but once we combine them, we get an image of the iodine component only and an image of the plastic components, or the plastic spheres only, which is all very good. But it's a fairly simple case because iodine and plastic have very different attenuation properties for X-rays. So the next challenge is to use to apply this technique to mammography. I'll go a bit quick here because I'm aware that I'm running out of time. But basically, you may have heard about mammographic screening. Mammographic screening involves examining with X-rays many people who don't have any symptoms to identify cancer in its early stage. It works very well. However, things can always be improved. So one option could be to, one interesting thing to do could be to identify people who are more at risk of getting breast cancer, examine them more frequently, and examine people who are less at risk less frequently, so that we optimize the use of resources. And it's well known in the medical community that breast density, which is the fraction of glandular tissue in the breast, is correlated to an increased risk of breast cancer. So a breast is made out of glandular tissue, which appears pale gray or white in an X-ray image, and fat tissue that appears dark gray. So our goal would be to try and effectively use our same decomposition algorithms to decouple the fat component of the breast from the glandular component. Because that could give us a good measurement of breast density, which is much better than the way things are done now, because breast density is just assessed qualitatively. So a radiologist will look at a person's mammogram and say, okay, this is around 75% glandular. We can do better. So we can use the same algorithms. The challenge is that now, so if you remember the graph I showed you before, soft tissue and bone have very different attenuation properties for X-rays. But here we're trying to discriminate soft tissue from fat. So they are very close in their attenuation property. So before we go into the lab to test a new idea, before we start using up lab time and so on, it's a good idea to see if in principle it could work to run a simulation. So we simulated an object that looked like this. So it was a block of fat tissue with a block of glandular tissue embedded at the detector at the back. So if our hypothesis is correct, so if our algorithm works correctly, we should get an image that has a 100% adipose tissue from this region, a bit less of adipose tissue from this region, and 0 here, and the glandular image should show only glandular tissue in the central region. And that's what we get. So that's our simulated image. So high adipose tissue on the left, medium, and no adipose tissue to the right where there is no object, and similar with glandular tissue. So the idea works. So now we are in the lab trying to implement this in practice. I will go very quick now. There are also some challenges, unfortunately, related to the detector, because in principle, a detector, a spectroscopic detector, is a fantastic piece of kit, but we have to apply corrections to account. First of all, for the fact that if a detector has to process the information from every single photon rather than from all the photons that have hit it in a certain amount of time, it struggles keeping up with all the information. So it is quite slow. So it's like whether you fill up a bucket of water, so you could either measure up the water content at the end, or you can measure every single drop that falls into your detector, into your bucket. So it takes a lot longer. And also there are corrections to be applied to account for the fact, for the way the electrical charges are created in the detector. Other challenge is the size. So you have seen a photo of my detector. A conventional detector is pretty much is a bit larger than an A4 sheet, and Hexitech, my detector, is just the size of a stamp. So to acquire a larger area, we need to tile the devices, which has a number of related challenges. So to conclude, these color or spectroscopic X-ray detectors are becoming more and more common for research, and they could potentially solve quite a few problems for medical applications. However, so we can, for instance, perform dual energy imaging with less radiation dose and no risk of what are called motion artifacts. However, there are still quite a few challenges to overcome, and research is going on. So that's it for me. Thank you very much. Are there any questions?
Thank you so much, Silvia. That was fascinating. We do have a couple of questions, so let's go into some of those, and then we'll go on to our second speaker, and we'll keep any further questions for the end when we get everyone back together. So a couple of questions have come through. The first one, bit of clarification, if you could answer this one, Silvia. One of our guests or one of our participants asked, what about the material? When you're putting an X-ray onto someone, you get the different contrasts. Some materials in the body absorb X-rays differently to others. What is it about the material that does that? Can you explain why we see so much contrast between, for example, the bone and the soft tissue? What is happening there?
There are two different factors that are in partly related. One is simple, the density. So basically, if you have an X-ray beam, the more atoms of a material it hits, the more likely it is to get attenuated. The other factor that is partly related is the atomic number of the material. So there is so the way so the parameters that so the interactions between X-ray beams and matter also depend. The probability of the different interactions depends on the atomic number of the material, particularly in X-ray imaging. A good chunk of the interactions that determine how much gets stopped and how much goes through is the photoelectric effect that you may have studied in school. And the photoelectric effect in the X-ray energy range increases very steeply with the atomic number of the material. So there are two factors mainly.
Right, so it depends on how many atoms do you have, how dense is the material, but also what it's made up of. And the heavier elements tend to absorb X-rays more. Is that what you said?
Yes, exactly.
Yeah,
so they have a higher probability, particularly
right.
of photoelectric effect.
Right, okay. And just really quickly, I was curious, I think you answered this, but I may have missed it. With the color X-rays, are you introducing in effect more X-rays, a greater dose of X-rays, which would make them potentially more dangerous on top of their utility? Or are you simply using the amount of X-ray that we've always used, we're just doing it a little bit more cleverly?
It's the latter.
Right.
So because what I have shown, so when I showed the spectrum, so the energy distribution of the radiation, basically that would account for one of the two images that you need for dual energy imaging. Then you can do something to the X-ray source, you can apply a different voltage and so on, and get the other image at a different energy. However, with our detector, so with a detector of this type, you can simply pick two of the energy components that you need from one of the two exposures, and that's enough. So it's in general less harmful for the patient.
Right. So you're getting more information, but for the same amount of X-rays. So that's awesome. That's great. Listen, stick around, Silvia.
Sure.
We're going to move on to the second part of our talk tonight, but we'll come back to you in a little bit.
Perfect.
So thank you so much
Thank you very much, and see you later.
Yeah, we'll see you in a minute. In the meantime, I'd like to introduce our second speaker. This is Dr. Cornelia Hoehr, who's Deputy Associate Laboratory Director, that's a good long title, for Life Sciences, a Deputy Associate Laboratory Director for Life Sciences, over at TRIUMF, which is Canada's National Particle Accelerator Centre in Vancouver, if I have that right. Her research is focused on medical isotope production and proton therapy. She's going to talk to us tonight about treating cancer with nuclear physics. So I'm going to hand over to Connie and let her take over the second half of tonight's seminar. Connie, over to you. Welcome.
Thank you, Chris. Perfect. Thank you. Okay, as Chris already alluded, I'm going to talk how nuclear physics can actually treat cancer. So we heard from Silvia all about imaging, and now we're going to switch to actually treating diseases, and in my talk specifically about cancer. So what is cancer? So cancer is a word that actually describes many different diseases that normally describes a growth that is out of control in the body. And here you can see different cancer occurrences between male and female. So for example, it's very, very common for a man to become prostate cancer. A quarter of all the cancers in men are prostate cancer, but only 10% of all male, of the population, the male population that has prostate cancer, only 10 then die, 10%. So prostate cancer is a cancer that can be treated well, while lung cancer is very difficult to treat. In women, it's very similar for breast cancer. Breast cancer is a common cancer among women, but it's not that deadly. But again, lung cancer is very deadly. And what that means is that some of the cancers we understand well, and and can treat well, and some maybe not so easy to treat, and we really need to look into what is the best way to treat the cancer. So how do we do that? So if you have cancer, the three main treatments, the mainstream treatments that are available to you is surgery, where you cut the cancerous growth out, chemotherapy, where you're giving drugs that on a chemical level attack the cancer cells, or you can use ionizing radiation that Silvia already talked about in the previous talk. That basically means that you ionize the cancer cells or around the cancer cells to try to kill the cancer cells. So what you would like to do is you want to give as much dose or destruction to really kill the tumor, but keep the normal tissue alive. So you want to affect the healthy tissue around the tumor or in the patient as little as possible, so there isn't any negative effect of the cancer treatment. And that's true for all three of these that I just mentioned. Now, what's a really, really sure way to kill a cell, cancer cell or healthy cell, is that you actually destroy the DNA in the cancer cell. And if you destroy the DNA in any cell, when the cell goes then through its cycle, it wants to separate and it wants to go into two cells and multiply. There is a mechanism in there, if you destroy the DNA, that it basically says, hang on, I don't know how to duplicate myself because my DNA is destroyed in the nucleus. I'm not going to do it. I'm going to basically die. So it's really, really, it's not the only way to kill a cell, but it's a really, really good way to kill a cell. What we want to do is we want to destroy the DNA, not just in one part, but in two parts. We want to make a double strand break because that's really, really difficult for a cell to repair. And again, we want to do this as much as possible in the cancer cell, but as little as possible in the healthy cells. So we can really dial in and only destroy the cancer cells and keep the patient free of as much as we can of side effects. Now for ionizing radiation, probably you heard some of these particles already in earlier talks. So we have different particles that we can use. We can use ions, for example, an alpha particle, which is 2 neutrons and 2 protons, or a proton or a heavy ion. And if we shoot that onto any matter, it goes into the matter fairly straight. It has these ionization events along the way, and then it stops depending on its initial energy. So that is one thing that you could do. You could also use a beta particle or an electron that will scatter quite a bit more and kind of spin out a little bit. You can use photons, as Silvia was using them in the previous talk, that will scatter even more and produce other photons and ionization events, or you can use neutrons as well. So all of these particles are available to us. And there is fundamental differences in how they interact with matter. They go in straight, or they scatter around, they stop at a defined point, or they go a little bit further and don't stop as hard as other particles. Another important point that these particles have that differ is something that's called the linear energy transfer. And basically what that is the density of these ionization events. So for example, imagine you have a DNA strand that you're trying to destroy in a cancer cell. If you have particles that have low LET, you have an ionization event here, and then you kind of miss the DNA, and then you have an ionization event here. So you're not hitting the DNA directly. But you can still kill the cancer cells because these ionization events produce free radicals that you may have heard. It's normally something to do with oxygen in water or in the blood. So you have free radicals that then can, in a second step, attack the DNA. And low LET particles are photons, electrons, some protons, and they do the damage indirectly. Or you can use high LET particles like protons again, or ions or neutrons, and their density of ionization events is so dense that you can hit the DNA directly and destroy the DNA directly. So that's another difference between the different particles. Now, how is cancer treatment typically done in hospitals all across the country? So most of the time, you have a small particle accelerator like this. This is a clinical electron accelerator, and linear accelerator. It's called an e-linac. There you have an electron source where you then accelerate electrons. And in the head here, the electrons hit a target, typically a tungsten target, and it gets converted into hard X-rays. And these X-rays then can be directed onto the patient. And these machines are fitting into a large, high-ceiling living room. So they're not overly large, and they're quite compact, and they are cost-efficient. They're easy to set up. They're very common. Most larger hospitals have one or several of these in the basement. There are many techniques how you can shape your X-ray beam to really only try to center it really onto the tumor, onto the cancer cell. Many different ways. And this is how the photons then travel, or the X-rays travel when they go into any material, including tissue of patients. You have dose, which is correlated to the destruction or the damage that you do. You have a little bit on the surface, on the skin, and then it rises very quickly, and then you have this very long exponential decay, basically. And if you would use this for cancer treatment, you probably would place your tumor about here. And then you could see that most of the destruction actually happens before you even reach the tumor, but you're not giving that whole treatment in one session. You spread it out over several weeks, typically 5 to 6 weeks. And the first day, you come with the beam from one side. The next day, you come with the beam from the other side. And the third day, you come from yet a different side. So you're always hitting the tumor hard, but you're spreading this out, the healthy tissue. You're not always hitting the same healthy tissue. And this is a very effective treatment. But you're always irradiating a little bit before and a little bit after. And these particles have low LET, a low ionization density. You can also use proton beams or heavy ion beams. And here the profile looks quite different. So again, if you're going into the patient, depth into the patient, we have a little bit of destruction again on the surface, on our skin. and then it goes in pretty flat. And then right at the end of the track, when the protons almost all stop, you have this peak, which is called the Bragg peak. And about 70% or so of the energy or the destruction is deposited in this peak. And the depth of this peak is only defined by the energy of the proton. If you use protons that are only 70 MeV, you have a peak about here. You have 230 MeV, you have a peak about here. So you can really tailor to overlap this peak with your tumor. You will still do some destruction before you reach the tumor, but basically no destruction after the tumor. It's also high LET in the Bragg peak, so you have very dense ionization, so you can hit the DNA directly. Now, the disadvantage of proton therapy is you need a very high energy accelerator. So these accelerators, they don't fit, well, they're typically larger, so you need a bigger facility. They're also way more expensive. Like in ELINAC, as we saw before, and I apologize, I know the Canadian dollar numbers, not the UK pound numbers. You can get one of these ELINACs for radiation therapy with photons for about 1.5 million, which in a healthcare system is actually not so bad. While a proton therapy machine to deliver the energy that you need to treat whatever you want is in the order of 50 to 100 million. So it's quite a bit more expensive. And you don't need it for all types of cancers. You really only need it for the cancer that is radiation resistant to photons. You need the conformity that you really overlap it with the tumor, and you need a high LET. So in summary, you can, here I just plotted different profiles so you can see the difference between photons and protons. I also have electrons in here. Electrons can be used with typical LINACs in the hospital only for surface tumors, like for skin tumors or very shallow breast tumors, for example. But these are the particles that we can play with in clinical settings. Right, so what does that actually mean in terms of a treatment plan? So in the next picture here, we have a patient, and we're looking from the top. You can see the two eyes of the patient and the nose, and here is the brain. And the oncologist has lined out where the tumor is in the brain. Now, if you would want to treat that with X-rays, probably would come from this direction here. And you can see that the highest dose actually happens before you reach the tumor. And again, we wouldn't always treat from that direction. We would spread it out. But you can see that you would give quite a bit of damage actually to the brain tissue, which is very sensitive to radiation before you even reach the tumor itself. If you do it with protons, you would come probably from a similar direction because you don't want to treat through the eyes. The eyes are very sensitive too. You can see most of the really high destruction would be in the tumor itself. So that's the advantage of protons, especially if you try to treat a tumor that is very close to an organ, for example, the brain, that is very sensitive to radiation. Now, at TRIUMF, we have treated ocular melanoma, which is a cancer in the eye. It's not a very frequent cancer. Not very many people do suffer from this type of cancer, but it's a lethal cancer once you have it. And here you can see an image, a fundus image of the eye where you go in with an optical camera really close to the eye. You can see this plaque here. This is the cancer before the treatment. And then if you do treat it with protons, the plaque, you could basically destroy it. You just see a little bit of discoloration. By the way, our proton therapy facility at TRIUMF was modeled after the proton therapy facility in Clatterbridge in the UK. And we treated from 1995 to 2019, we treated patients clinically. How does this look over across the world? Basically, so proton therapy or ion therapy is an increasing modality. We have quite a few in North America. There are 5 in the UK, including the oldest in Clatterbridge, which is in the 1980s, and the newest one in London in 2021, I think that it opened, and quite a few in other parts of the country. And there are many more under constructions and in planning. So it's a good treatment if you really need the high LET and a really sharp peak for therapy. But sometimes, especially if your tumor that you have in the body, it may not be nice and compact and in one solid structure. So sometimes you can have cancer that has spread completely throughout the body. Here we have an example of a prostate cancer patient out of Heidelberg in Germany. You can see in the image that the cancer has spread. All of these are metastases, the dark spots here. By the way, this image has been created with another nuclear medicine technique where you take a protein that attaches to these cancer cells and you put an isotope onto it that sends out photons outside of the body that you can image. So that's how you get this image in a PET scan, positron emission tomography scan. Now, this patient had chemotherapy, other radiation therapy, hormone therapy, and basically the medicine couldn't help this patient anymore. So what they decided to do is, instead of using this protein to create an image, why don't you attach an isotope to it? An isotope to it that sends out, when it decays, a high LET particle. For example, an alpha particle that we saw before is a high LET particle. And then the protein will go and will accumulate into the metastases across the site. That's what they did in Heidelberg. And this is a scan afterwards. So they injected again this compound. And you basically can see that all the metastases has gone away. This is just because you inject it into the bloodstream. It will accumulate in the kidney and then in the bladder. Basically, this patient has been cured of this prostate cancer that couldn't be treated any other way. And he went on to live some more years. Now, the problem is that actinium-225, this radioactive isotope that can emit one of these high LET particles, is not very common. It's actually difficult to get. It's normally procured out of stockpile of nuclear weapons or nuclear reactors, so it's not very common. But it would be really nice to have it quite available, because it seems to be very, very good in actually treating cancer. For example, 60 to 80% of all these prostate cancer patients do react to it, which is an incredible high number in a medical setting. So we want to have lots of this actinium-225 so we can treat prostate cancer and maybe also other types of cancer. So it turns out that at TRIUMF, with our very large accelerators, we have the ideal setting to actually make it. And we started making actinium-225, as have other really, really large nuclear physics labs. And here you can see our first batch that we made about 2 years ago. And we made it since, and we give it to our collaborators so they can make these pharmaceuticals that we can then use to improve cancer care. So that was pretty much what I wanted to talk about in nuclear physics. Just a little bit about me. As you probably can hear from my accent, I'm originally from Germany and I'm now in Canada. I did my PhD in atomic physics. So my career wasn't quite that straight. I started out in atomic physics, then did several postdocs, and then went into medical isotopes and proton therapy at TRIUMF, and now I have a small research group at TRIUMF. And I do get to test detectors for medical physics and play around with medical isotopes and figure out which ones are the best one for medical. I supervise graduate students, including some of the UK. Earlier this year, I had 2 master's students from the University of Edinburgh. And I would like to thank you for your attention. This is the bigger department that I'm working in. And thank you.
Thank you so much, Connie. That was fabulous. Stick around. We've got time for a few questions. So, Connie, I've got a couple for you, and then we'll bring Silvia back in, and we can just have a bit of a general chat. The first question that came through for you, on one of your graphs, you showed the proton therapy and the proton dose or damage, if you like, as a function of depth, how far it goes into the body. And one of our viewers asked, why is it that you don't get terribly much damage over short, but then at a particular range, suddenly it just dumps all its energy? What's going on there? Why do you get that peak?
That is a very good question, Chris. So when a big particle like a proton or an ion goes through matters, most of the interaction that it does is actually not with the nucleus, it's with the electrons, the electron cloud around it. And electrons are about 2,000 times lighter than the proton. So it goes through and the electrons are bouncing off. That's the ionization that we talk about. But like a bowling ball, if you throw it into the pins, it goes straight and everything just jumps out of the way. until it gets really, really slow. Then all of a sudden, then it can have a lot of interaction. That's when it loses most of its energy. So basically, it's just the mass difference between the protons or the ions and the electrons where most of the interaction happens.
Right. Okay. So it's actually because of its energy and because of its size, it takes a while. It goes through a certain amount of tissue before it gets to the point where, okay, now I can really interact.
That's
and you
right.
can use that to your advantage. So one of the other questions that came up was using protons as opposed to X-rays. They have that very different profile over depth into the tissue. What does that mean in terms of side effects? I mean, do they cause different side effects? You might do different amounts of damage, but they're different kinds of radiation. So do you get different kinds of side effects? Can you talk to that?
So in the bigger picture, no. So both photons and protons, they ionize. So they cause ionization, they cause damage, they cause free radicals that then can go and attack the cells. So in the end, it's the ionization that causes the side effects and causes the cell damage or the cell kill. So what you want to do is you want to really reduce the amount of ionization to the healthy tissue. And that is different because of the depth profile, but the mechanism of the damage is the same. So you get kind of very similar side effects, which is, for example, dry mouth, or you lose hair, or you have burn-like symptoms on the skin. You can lose appetite and weight. So that's basically the same for photons or protons, just the amount.
Right. Okay. Listen, at this point, what I might do is invite Silvia to join us back again, because we have some questions which are left over from Silvia's talk at the beginning. There's a couple more for you, Connie. We've got some general questions. So thanks for joining us again, Silvia. Why don't you throw your microphone back on there so that we're ready to go? One question which I'm going to broaden out, it's just come through, but I think it applies to both of you, really. We're talking about both X-rays have been around for a really long time, and nuclear medicine, nuclear therapies have been around for a while, but we're getting better and better at them. We're introducing more and more technologies, more and more applications, different and more sensitive detectors, different ways of producing particles. Is this becoming a lot more expensive? Is this something which we're going to be actually able to see in hospitals around us in the immediate future, or is it going to take a little while? Silvia, color X-rays. Is this an expensive technology that's going to take a little while to come through?
Well, clearly, when you develop a new detector, the initial costs are a lot more. So once it becomes mainstream, it enters a mainstream production, I don't expect it would be much more expensive than a standard X-ray detector. So clearly now it is, but as I said, we're quite far away from having a detector like this one in front of a patient, because it's this size as opposed to this size. However, there are already some partly spectroscopic detectors that are embedded in CAT scanners, so the medical procedure where you have a beam and a detector going all around the patient, and you end up with cross sections of the patient. So there are some devices that have detectors that give a small number of different energies as opposed to a whole continuous range.
Right. So in your case, there's a lot of development costs going on here. You've got to make the technology, and then you've got to figure out, how can we make that smaller? Can we get that smaller? Connie, in your case, we're talking about different kinds of particle accelerator, basically. You're talking about producing different kinds of beams of particles. Is that where the cost comes in for yours?
That's one of the big parts of the cost. So typically right now, proton therapy is about, as a rule of thumb, twice as expensive as traditional radiotherapy with photons or X-rays. But just recently, one of the vendors that actually make these proton therapy facilities, the machines are getting smaller and smaller, and they managed to make one machine that is so small that actually can fit into a typical room where an ELINAC typically fits. So it's getting a lot of technical development, and because of that, it is becoming cheap. So it's just the more you work on it, and the more you make, the less expensive it can be.
Yeah, it's getting there. It's getting there. You can get it small to a certain point. You're not getting it down quite to Sylvia's postage stamp size, but it's getting room size is good.
Yeah.
Another question which came up.
We need bigger and they need smaller.
Yes, exactly. Listen, we've got the two of you presenting two different sides of nuclear medicine tonight. We've got the imaging side, detecting what's there. We've got the therapy side, which is now that we know that it's there, what are we going to do about that? Are there different cancers, or how does the imaging and the therapy work for different cancers? Are there certain cancers which are more easily imaged? Are there certain cancers which are more easily treated with radiation? Silvia, why don't we start with you on the imaging side?
Well, on the imaging side, clearly it very much depends on the size of the cancer and also where it is, because in some cases it stands against a uniform background, so it's fairly easy to detect it. For instance, lung cancer, you have the rib cage in a way, but you have a solid mass against lung tissue that is spongy, effectively. So in general, it may be easier to detect it. It clearly depends at which stage you detect it. Breast cancer, which is my specialty, has the problem that you have a mass that stands against a non-uniform background. So because it has similar attenuation properties to the background, and it also, so basically the background masks the visibility, it may be trickier to see very small tumors, which is where we would like to be ideally in terms of addressing the issue quickly.
Sure. Okay. Connie, about what on your side? Are there cancers which are more or less amenable to radiation therapy?
So some cancers, some cancer types are actually they just die faster in radiation than others. And one easy way to explain that is, if you remember with X-rays, you're not hitting the DNA directly. You're actually killing the cancer because you have oxygen around that creates free radicals. And if some cancer types have a lot of oxygen around, and it's the cancer type and the cancer age or size, and some cancers are devoid of blood or oxygen, they're called hypoxic. So then it gets really, really difficult to treat them because you can't create these free radicals that then attack the cancer nucleus. In those cases, you really need the particles with the higher LET, the higher ionization, so you can hit the DNA directly. So that's I guess an easy way to understand why different types of radiation can treat different types of cancer differently.
All right. Listen, we've probably got time for just one more question, and I'm going to put this one in there on behalf of the masterclass participants, because these are typically young people who may be looking for jobs and careers in the future, wanting to pursue something which is for the good of humanity. So my question to you is, look, medicine used to be really quite a blunt instrument. We used leeches, we cut people open and pulled things out and had a look at them. And now it seems to me to be incredibly high tech, and particularly relying increasingly on high tech physics. So is medical physics a growth area? Is this a good area to get into? What do you suggest? Connie, why don't we start with you? Is there room for lots of new students in medical physics?
Oh yeah, for sure. So all these different techniques that we are fine tuning, and basically what we're doing is we take the imaging that Silvia alluded to, and we try to really nail down what it is exactly what we want to treat specifically to that patient. And then we're going to come with the different treatment options and apply the one that's best for it. It's called personalized medicine. But it's you need a lot of expertise to it. You need to make sure you understand the imaging results and you can apply it. So it's very much a growing field for medical physicists that can really then go into the clinic and work side by side with the medical doctors to really make a difference. Because exactly what you said, you don't want to just use the old way of, I'm going to throw radiation at somebody and then I'm going to, hopefully it works. So you really want to tailor it down to make it as precise as possible. And you need a lot of medical physicists next to the medical doctors.
Silvia, I'm assuming you would agree with that statement. Is there a lot of room for medical physicists in the future?
I most definitely agree. There is so much going on right now because you could get into medical physics and work more on the technology. You could work, for instance, if we're talking about nuclear medicine, you can look at radioisotopes, how they target specific regions of the body. You can be developing new techniques. Clearly, there is always room for improvement. Maybe using parts, areas of physics that haven't been used for clinical applications. So there is definitely lots going on right now, and there are definitely jobs around.
That's you can't get much of a better sell than that. Listen, we are going to have to bring it to a close there. Can we have a huge thank you for our two speakers, Silvia and Connie? Use your reaction button down the bottom of the screen and send them loads of love through the Zoom chat. Thank you so much for joining us, everyone, particularly masterclass participants. Look, if your question came up and we didn't get a chance to address it, go onto the masterclass website and ask it in the forums. We've got actual real live physicists there waiting for your call to answer your questions directly. Remember that this has been recorded, and so we're going to have a little bit of an edit of that, make it nice and pretty, and throw it up onto the masterclass website sometime over the next week or so. So keep an eye out for that and come back and revisit it. Otherwise, that's it. We'll see you for the 4th masterclass webinar. This time next week, we're going to dig right down into the nucleus to figure out what exactly is going on down there inside all of those protons and neutrons. Thank you so much for joining us. Thank you to our speakers, and we'll catch you next time. Good night, everybody.
Thank you. Good night.